All right. Hello, everyone, and welcome to the webinar panel, Balancing Beliefs and Care, Navigating Healthcare Conscience Objections. My name is Reverend Karen Bona. I am Senior Healthcare Associate for Tannenbaum, and I'll be moderating today's panel. We'd like to start by thanking the E. Rhodes and Leona B. Carpenter Foundation for providing funding for this panel, as well as for our updated e-learning on conscience rules. This interactive e-learning will be available soon for free on our website, tannenbaum.org. Today's panel, as I said, is being recorded and will be added to Tannenbaum's YouTube channel shortly. The Tannenbaum Center for Interreligious Understanding is a secular, non-sectarian, nonprofit organization. We promote justice and build respect for religious difference by transforming individuals and institutions to reduce prejudice, hatred, and violence. As a secular, non-sectarian organization, we don't promote religion or any specific faith, but rather recognize that religion and spirituality can be powerful forces in people's lives and address them as such in 4 programmatic areas: peace building, education, workplace, and healthcare. It's my honor to introduce our distinguished panel who will be addressing the complexities of conscience objections for us today. Kristin Collier, MD and Fellow of the American College of Physicians, is an Associate Professor of Internal Medicine at the University of Michigan in Ann Arbor, where she serves as the Director of the University of Michigan Medical School Program on Health, Spirituality, and Religion. She is an Associate Program Director for the University of Michigan's Internal Medicine Residency Program. She earned her MD and completed her training, including chief residency, at University of Michigan hospitals. Her academic interests are in the overlap of spirituality, religion, and medicine, and her peer-reviewed work has been published in multiple high-impact journals. Dov Fox is the Herzog Research Professor of Law at the University of San Diego, where he founded and directs the Center for Health Law Policy and Bioethics. Named Professor of the Year for both teaching excellence and outstanding scholarship, he also holds the university's highest academic honor bestowed on faculty in any field. His research is frequently discussed in popular outlets such as the New York Times, the Washington Post, and the Wall Street Journal. His latest book, forthcoming with Harvard University Press, is called The Conscience of Care: Navigating Health in the Culture Wars. And Abram Brummett, Ph.D., is an assistant professor of clinical bioethics at Oakland University William Beaumont School of Medicine, and also a practicing clinical ethicist at Corewell Health William Beaumont University Hospital. After earning his doctorate in healthcare ethics from St. Louis University, he completed a 1-year postdoctoral fellowship in clinical ethics at Albany Medical Center, where he engaged in ethics consultation, education, and policymaking. He's published widely on the topics of ethics expertise, conscientious objection, and bioethics and religion in top academic journals. My deep thanks to each of our panelists and all those attending live. If anyone experiences technical issues, please reach out via the chat to my colleague Emily, who's monitoring the chat in the background. Because of the depth and breadth of the content we're going to cover, we won't be doing a Q&A today. We've worked together to develop a set of questions that will maximize our panelists' abilities to share their knowledge and expertise with us. So with that, I'll get us started by sharing Mark Wicklaire's definition of conscience or conscientious objection, and it is this: physicians, nurses, and pharmacists engage in acts of conscientious objection when they, 1, refuse to provide legal and professionally accepted goods or services that fall within the scope of their professional competence, and 2, justify this refusal by claiming that it is an act of conscience, which is understood as one's inner moral or religious values that are deeply held, the violation of which would lead to intense shame or loss of self-respect. All right, so with all of that and that weighty definition, let's dive right in. Dr. Collier, Could you begin by addressing conscience objection from your experience and training as a physician, and also share your personal experience with conscientious objection?
Sure. Thanks so much, Reverend Karen. I'm grateful to be participating with my colleagues on this important topic. And again, thanks for the Institute and our stakeholders for making this possible. So I'm really grateful for what Reverend Karen said about this definition to get us started about what conscience objection is, and I fully agree with the definition given. I think it's important also to maybe give a little bit of a more fuller definition of what our conscience itself is, since I'll be speaking about that from the perspective as a physician. So what exactly is our conscience? Well, the way that I'm using it today and aligns with the way others have defined it in this context is this. Your conscience is a commitment to acting in accord with what one knows to be right and good. It's a commitment to acting in accord with what one knows to be right and good. So conscience, therefore, in this definition, has two interrelated functions. It involves a commitment to know and understand morality and a commitment to act with integrity. So conscience, I would say, therefore, is principally concerned with an existential commitment to living in accord with one's own considered understanding of the moral structure of reality. And I think noting this emphasis on action, I think will be sort of salient to what we discussed today in this definition I've provided. So it's one thing to know the good, right? But it's another thing to live that way or to act in a way that aligns with that knowledge. And so as a physician, this involves me thinking about moral judgments on cases. I would sort of equate this with wisdom. It's a cognitive judgment, really, that we should be pursuing good and avoiding evil. So that's how I'll be conceptualizing conscience in our conversation today. And then I also think it's important also in these conversations to point out what conscience is not. It's not a whim. It's not a preference for like pistachio ice cream, for example. It's an integral part of human moral psychology, and I would say an essential feature of the moral and technical rationality of a good clinician. And I would say also has a duty to be rightly informed. And, as we consider our examples today, it's not something I think that we can just take on and off like some type of hat, but it's integral to who we are. And I just want to point out also in the definition that Reverend Karen gave us on conscious objection, I want to bring out maybe a few specifics that might be helpful to highlight. So in the definition, Reverend Karen, that you gave for conscience objection, two components to it are the services and goods that are being objected to must be legal and professionally accepted. And I think when I think about conscience objection historically, for example, when we think about conscience objections to war, for example, the term has been used to describe a process by which a person with a relatively uncommon moral or religious conviction is released from performing an almost universally recognized legal duty. But I would say in our current cultural moment, conscious objection in healthcare is almost always directed towards a practice or procedure that is still very much contested or within Overton's window. Even though things like abortion and physician-assisted suicide, for example, are legal in many states and somewhat professionally accepted by certain medical societies, these practices are not practiced by most physicians. And there is still ongoing conversation amongst various stakeholders as to how accepted these procedures should be within the vocation of medicine. And I also want to note here, which is provided in the definition, that conscience refusals are not just are just related to services and procedures, that they're not related to people. So we are not ever justified in turning away people or groups of people. We can refrain from providing services or treatments or procedures that we don't think align with the goals of medicine, but not seeing people themselves. I know Dr. Brummett's going to talk about that distinction a bit. And lastly, given our foundational concepts, I also want to point out a couple things that conscience objection is not something just religious people do, right? The defining feature of a conscience objector in medicine is that they are opting out of a provision of a service or a treatment or procedure because they believe the service would be harmful to the welfare of the patient in front of them, or in some way contrary to the goals of medicine. And I would say that both religious and non-religious people have commitments. They could have commitments, right, that exclude them from procedures or services that they deeply believe go against the goals of medicine or would be harmful to the patient in front of them. And second, conscience, I would say, in medicine is not solely confined to a small set of socially contentious procedures or treatments that get all the glittery attention all the time that we talk about a lot, right? Euthanasia, abortion, et cetera. We in medicine are required to make complex judgments in a variety of areas all the time, every day, about the ethical advisability of medical care. And I would say we should have latitude to do so. So I'm now just going to take just a brief few minutes to talk about my own personal experience with conscience objection. We all should hopefully realize that in a healthcare encounter that there are two moral agents coming together, the physician or the healthcare professional and the patient. And they both have their own commitments, their own beliefs and agency. And in this, we can see how the exercise of conscience can play out on both patients and on healthcare professionals. So I'm just going to take a few minutes to talk about the effects of healthcare physicians' conscience on providers from my experience, and Dr. Brummett will talk about the effects that physician conscience objection can have on patients. So in the summer of 2022, I was notified that I was chosen to be the faculty member to give the keynote physician address at our medical school's white coat ceremony. I was voted to be the faculty member amongst all of our faculty by our medical school's chapter of our Gold Humanism Honor Society, which recognizes humanism in medicine. And it's really such a great honor to be chosen for this, probably even more so than our graduation talk, because you are the first faculty member to welcome the new medical students into the profession. So I accepted and emailed my mom and all my colleagues and my mentors. Shortly thereafter, the Dobbs decision came down. And on that same day, an interview I had done with a writer came out about my conversion from being a pro-choice physician to a pro-life one. And there was, rightly so much emotion at my institution with the Dobbs decision. And shortly thereafter, a petition was started to have me removed as the speaker from the upcoming white coat ceremony due to my pro-life views. The local news started carrying the story. It was a very stressful time. I continued to go to work and teach and see my patients. And every day I walked through the medical school on my way to class, and I passed by a sign that had been hanging up for months on a bulletin board posted by the Diversity, Equity, and Inclusion Office. And it said, "Every voice counts." It said, "Every voice counts. Our community depends on it." So it got me wondering, does every voice indeed count? Or are these just words on a sign? What about my voice? Did this not apply to me? And I felt that I was being faced with an identity-based attack. I wasn't even going to be talking about abortion. I just was going to welcome the new medical students and accept an invitation to do so. But because of my identity of who I was and what I believed, that in part flows in part out of my religious identity, I felt like I was being targeted. I knew I had a right to speak and that our faculty handbook at Michigan actually supports our faculty doing scholarship and having views in contested spaces. And in the end, the administration did the right thing. They supported my invitation to talk and publicly said so in an email that they distributed to the faculty and the students and the staff. And the email was sent out by Dean Runge. And at the end of the email, he said something like that our values speak about honoring the critical importance of diversity, of personal thought and ideas, which he says is foundational, which I agree, to academic freedom and excellence. And he says we would never revoke a speaker because they have different personal ideas than others. So after that, I was invited to all the white coat planning meetings. I was assigned a bodyguard for the ceremony. They increased the security presence at the event. And the day of, at the beginning of my comments, several students and members of the audience got up and walked out, and someone in the audience recorded it. And the video that night started going viral on social media. My husband woke me up the next morning saying, "Kristin, it's a top story on Fox News," which is like my worst nightmare. And every major news outlet has carried the story. And the next several days, honestly, were a blur. Death threats, media requests. They got a hold of my husband's cell phone, my cell phone. And due to security concerns, I was told to drive a different way to work and park in a different spot and alert my neighbors, the whole 9 yards. So yes, my right to talk was protected. And my institution has had policies in the books for decades, actually, that protect healthcare providers' conscience to opt out of procedures or services that they feel are an affront to the goals of medicine. But there still were significant costs that I bore that day and in the aftermath, and that I continue to bear because I hold a somewhat controversial opinion in the profession of medicine right now. And I'll remind our listeners, though, that around, for example, the issue of abortion, which is what my situation was around, that the majority of the OB-GYNs in this country don't even perform abortion, and that abortion and things like physician-assisted suicide are still very much contested issues within medicine and society. And so given the contested nature of these practices, it seems like there should be space made for physicians like me in medicine who hold a variety of beliefs about these practices. And even though there are legal protections for healthcare professional conscience, there are still social costs for exercising that conscience or even talking about it. I still, 3 years later, receive hate mail. I've been dropped from panels. People don't want to sit with me in conferences, panels, and projects have been taken from me. The thing that bothers me the most really are relationships that have been fractured with colleagues at my place. I think are forever broken, and I can handle it. And the cost of bearing this is worth it to me. And I recognize the immense privilege that I have in being able to bear this well. But I often feel like we don't fully recognize the cost that dissenters can bear, even when their legal rights are upheld. And this isn't to minimize the costs that patients bear, like not at all. But I've been asked to speak today to the healthcare provider perspectives in my remarks. And I'll end my formal remarks with what the American Medical Association, or the AMA, currently says about physician conscience. So they state that physicians are moral agents in their own right, and like their patients, are informed by and committed to diverse cultural, religious, and philosophical traditions and beliefs. And they state actually that preserving opportunity for physicians to act or to refrain from acting in accordance with the dictates of conscience in their professional practice is important for preserving the integrity of the medical profession, as well as the integrity of the individual physician on which patients and the public rely. Thank you.
Thanks so much, Dr. Collier, for your vulnerability, your openness, and for really getting us into the issues of integrity and morality, and not just the difficulty of taking a stance, but what happens after, the consequences of taking a particular action. So thank you quite a bit. My next question is for Professor Fox. So now that we've gotten a medical and personal perspective on conscience objections, could you provide us with an overview of the current legal landscape with regard to conscience and conscientious objections in healthcare?
Thanks, Reverend Bona, for convening us here today at something of an inflection point for conscience and its role in the practice of medicine and the rule of law. Dr. Collier, what a bracing story about the personal impact of your appeals to deeply held moral beliefs about the sanctity of life at any stage in human development by refusing to extinguish it, including during a pregnancy. I share with you a view of conscience that is expansive, one that reflects the diverse and dynamic and pluralistic practice of medicine and our multicultural democracy. I think it is often much better off for preserving that space for people to live in accord with those core convictions that they hold, at least within certain limits. I think most importantly, the impact of accommodating those claims of conscience on vulnerable, innocent third parties that might be the state, that might be private institutions, that might be individuals like patients. In my remarks, I'd like to answer Reverend Bona's question about the law and also suggest that the very definition of conscience that Dr. Collier has endorsed also supports its recognition for a different kind of clinician, rather medical professionals who have very distinct sorts of moral commitments about how they practice medicine. To back up a bit, on this perspective, I think it is helpful to start again with Dobbs, again coming from a different vantage point. Within weeks after the fall of Roe, more than a dozen states made providing an abortion a felony, changing what had been health care to a crime. One punishable by up to a life sentence in some states, with almost no exceptions. Not for rape victims as young as 10 years old in Ohio and Mississippi and Louisiana, who became mothers in grade school, one who gave birth clutching a teddy bear, not for the cervical cancer survivor who had to drive 10 hours to New Mexico from Texas after learning that the baby boy she'd hoped to have was doomed by a fatal diagnosis. Not for the Texas woman who almost died after she was turned away for ending the dangerous pregnancy that left her condition too unstable to travel out of state. Not even doctors feared, at any rate, for the Georgia patient with acute severe sepsis, who did lose her life after she was declined abortion care for over 20 hours, as her condition steadily deteriorated until her organs eventually failed and her heart ultimately stopped. In cases like these, healthcare providers might claim their own heartfelt commitments to patient care. Now, we're used to hearing about physicians or pharmacists who claim conscience to deny interventions that their employer or their profession or their government expects of them, but they deem sinful or wrong, whether that commitment to the sanctity of life or the commitment Dr. Collier specified about what medicine means, morally speaking, to physicians, about what it means to practice morally, those deep normative purposes that medicine has. Conscientious refusers are who we think of when we contemplate conscience and conscientious objection in medicine. And that, I think, is how Dr. Collier defined it and understood it. And I think that is consistent with our larger understandings. Less familiar in this public discourse are clinicians who also have strong moral reasons for providing care to the people who come to them seeking it. Institutional or state restrictions, like those ones after Dobbs, but also by institutions that would prohibit clinicians who work there from providing everything from abortion care or birth control to gender transition care to aid in dying. These restrictions, and there's never been more in the history of the United States than there are today on who clinicians can treat and how, run up against the conscience of providers who feel that practicing medicine according to their education and their training, professional standards of care, is incompatible with those restrictions. And that, I want to suggest, is also a matter of conscience. That is the basis for conscientious objection that just about every state and a couple dozen federal laws purport to protect absolutely. And this is one key feature of the legal landscape in the United States, only for clinicians who would refuse care, those who are unwilling to provide care that is required or expected of them, and not for clinicians who would provide it according to their conscience. On the one hand, conscientious refusers enjoy near complete immunity, not from the social consequences, certainly that Dr. Collier describes so vividly, but from whatever legal penalties they would normally face for violating professional standards in ways that harm patients. Causes of action, for example, like informed consent, medical malpractice, patient endangerment, or abandonment, all of these fall away if a doctor would otherwise have violated them by virtue of the care they refused, but claim conscience as the reason for doing so. And state and federal laws codify and vindicate that affirmative defense of conscience, again, just for conscientious refusers in the practice of medicine. Now, for all the solicitude that conscience clauses afford to refusers, there's next to none for conscientious providers, who are just as morally committed to providing evidence-based care as a matter of their own moral scruples. Now, nowhere else in the world vindicates conscience as this one-sided kind of trump card. Some countries don't offer any special dispensation to medical objectors at all. Other nations exempt conscientious refusers only under narrow circumstances from the expectations that clinicians provide medically indicated care. Only in the US does claiming conscience mean that refusers can't be fired for violating their employment contract, can't be held liable for committing what would otherwise be malpractice, can't have their license suspended for breaching informed consent or professional duties upheld by state medical boards, can't be prosecuted for endangering patients or abandoning them if their refusal would otherwise qualify for those offenses. It doesn't matter if conscientious refusers are even the last physician in town, the only one who would be able to provide that care. They don't even have to tell patients what their medical options are. That a practice or procedure that would be medically indicated for them is even an option would they be able to pursue it elsewhere. Conscientious refusal is in this way protected without condition and without consequence. And there are just two limits on clinicians' freedom to conscientiously deny care in America. First is the invidious kind of discrimination that's prohibited by civil rights law on the basis of patient characteristics like race, sex, or age. The other limitation is urgent health crises in a hospital ER. They can't be turned away, patients, in that very narrow context either. That doesn't apply outside of ERs and not even in the ER if it's not an emergency. And even if it is, there's no recourse for someone who were turned away in an ER in an emergency to sue anyone for having failed to treat them. The only recourse under the law is to ask Congress to investigate an institution and withhold funding for it if it finds a violation. So there are lots of protections and very few limits on legal shields for conscientious refusers. By contrast, when it comes to conscientious providers, there are no such protections. The Supreme Court, in a case this summer, even declined to issue a substantive ruling on whether a federal law that requires emergency care would give doctors legal cover to provide a life-saving abortion when a health-preserving abortion, if it's not also required to save a life, even if that pregnancy, its continuation, places a woman at grave risk of health consequences that could include losing the chance for the safe pregnancy to have a wanted baby in the future. Now, most abortion bans do have very narrow emergency exceptions for saving the life of the pregnant person, but those exceptions are very narrow and they don't specify how bad a harm must be to qualify, let alone how likely or imminent. So treating physicians are left to wonder, what if a delay in abortion care would cause an unavoidable hysterectomy? Or if the timely cancer treatment that someone needs isn't compatible with continuing her pregnancy, or if complications from her diabetes or her seizure disorder would risk blindness or brain damage for continuing that pregnancy. These laws don't say if performing an abortion is legally permissible in those states. Now, some doctors have and organizations have called for civil disobedience. The New England Journal of Medicine, its editorial even pressed doctors nationwide to defy criminal restrictions on providing abortion and accept that they would just lose their license, even go to jail for doing so. I think this sacrifice is too much to expect of what I've called conscientious providers, at least if a patient's life isn't on the line. I limit the kind of conscience that I think is worth protecting in two ways. One, that the civil rights laws recognize non-invidious discrimination, that is, refusals that have that reflect negative attitudes about patients by virtue of their unfavored characteristics. And second, if those objections are based on erroneous assumptions that are demonstrably false by reference to very clear medical evidence. There, I think conscience, whether for refusers or also providers, should not be protected, even if they are very sincerely held beliefs. What I would suggest is that federal and state lawmakers and judges would adopt a partial legal defense to abortion ban prosecutions and other penalties that would mirror something like the protections conscientious refusers get. Now, this would reduce the penalties for medical professionals who break the law out of their deeply held moral commitment to provide care that falls within the medical norm, not outside of it, but within it, and not erasing those penalties or punishments or offenses, but mitigating the penalties. This would be designed, again, coming back to my opening remarks, in concert with Dr. Collier, to respect democratically enacted laws or their core prohibitions while vindicating clinician conscience in ways that individualize justice for those clinicians who claim it and affirm the moral diversity and pluralism of the medical profession and of our democracy at large. Thank you.
Thank you, Professor Fox, for that impassioned description of the legal landscape and for really giving voice to the asymmetry, to the perspective of conscientious providers as players in our diverse, dynamic, pluralistic field of medicine and our American democracy. I found that very useful and informative, so thank you. Professor Brummett, it's your turn. Could you share with us what led you to develop such a deep interest in clinical bioethics, and also help us better understand the various ethical views related to conscience?
Yeah, thanks, Reverend Bona. And I just want to say thanks also to my great colleagues, Dr. Collier and Professor Fox, for joining me on this panel today. To make a long story short about how I got into this business of being a bioethics professor, it was basically my mom. My family is not Catholic, but my mom worked for the Catholic Health Association in St. Louis, Missouri for 30 years. And I was a philosophy student, and, she was like, hey, there's these people there that do bioethics, and maybe you should come talk to them. And I did, and, changed course into bioethics, and I've been doing that ever since. So, given that, what I wanted to touch on today was sort of the moral conceptual landscape of views that one can take with respect to the accommodation of conscientious objection. So Dr. Collier has talked about her personal experience from the perspective of a physician. Professor Fox has laid out sort of the legal landscape on this issue, but as we know, the law and the ethics on any issue are distinct. So I'm going to focus on the ethical landscape. When thinking about different views towards the accommodation of conscious objection, there's basically three questions that are really good questions to ask yourself to start developing a view of conscience. The first one is, what kinds of things ought we to protect? What kinds of conscious objections ought we to protect? And the sort of thing that might come out here that I'll talk about more in a moment is, should we only protect conscious objections to providing medical goods and services, or should we also sometimes protect conscious objections to treating certain types of individuals? Right? So that's the kind of thing that's going on in this first question. What kind of objection should we protect? The second thing is, we might decide that we want to protect a certain kind of objection, like an objection to abortion, for example. But are there certain contexts in which we wouldn't want to honor the objection? So that the kind of context examples that I have here would be like the emergency room in the context of a medical emergency. So we might say objections to abortion should be accommodated, but not in the context of a medical emergency. Or we might worry about the context of what Professor Fox described of what we call a conscience monopoly, which is where maybe you're in a rural setting or just an area of the country where there's one physician, and the only physician that you can really go to has a conscience objection. We call that a conscience monopoly. So you might want to include maybe a conscience monopoly or an emergency setting as contexts where you wouldn't want to allow an otherwise permissible conscience objection. And the third kind of question to ask yourself is, if we're going to allow a certain kind of objection and we're going to allow it in certain contexts, what kinds of moral obligations does the objecting clinician have? Does the objecting clinician have, for example, a moral obligation to inform the patient that they are in fact refusing for a reason of conscience? Do they have a moral obligation to give what we call advance notice of one's conscience refusals to the patient population that they serve, so that patients aren't surprised, at the clinical visit that that particular office or physician has an objection? And most controversially, is there a moral obligation to refer a patient to a provider that the objecting clinician, believes will provide the service that they object to? So when you kind of work through those three questions, there's three general views that you can arrive at depending on how you answer those three questions, okay? If you think, well, basically the answer to the first question, what sorts of things should be accommodated, that the answer is, well, nothing should be accommodated. Then you're what we would call a conscience or an incompatibility thesis. That's the name of that view, that conscience just has no role in medicine. Again, I'm not describing the law, right? I'm describing the conceptual space that one could take ethically with respect to this issue. But on the very opposite end is a view called conscience absolutism. And conscience absolutism says that conscience should always be allowed in any context with no obligations to the objecting provider. Now, it's hard to find someone who actually defends this view, but again, as a heuristic of the conceptual space here, this is what the other extreme would be, this view of conscience absolutism. Now, as you might be thinking already, there's a lot of space in between thinking that we should never honor a conscience objection and thinking that we should always do it. And that whole space in between those are the compromise views of conscientious objection. And there's different versions of this, right? So some compromise views might think that you have a moral obligation to refer, and some might not think that you have an obligation to refer. But they're both compromise views because they want to allow conscientious objection within some limits. Having said all that, I think Professor Fox, I'd be curious to hear what he thinks about this, but I've seen the current legal landscape described as more towards the conscience absolutist side of that framework that I just laid out, because of the very limited constraints that Professor Fox described around anti-discrimination and EMTALA in medical emergencies. I want to take my last couple of minutes here to refocus on what I called earlier the people-procedure distinction. So the answer to that first question, what kinds of objections should we allow? And because Dr. Collier was so kind enough to provide her personal story about conscious objection from her experience as a physician, I thought I would provide my own personal perspective from the patient perspective of this issue. So when I was in graduate school, I once went to the health clinic that was, part of my free health coverage for my graduate program. And I met with my physician. And this was the best physician I had ever had. I will always stand by that. This physician was so attentive. We had such a great relationship. And one day I went in And I described to him that I would like to have a prescription written for PrEP. PrEP, P-R-E-P, is a preventative medication, I think often taken in like a daily form that anyone can take to sort of block the transmission of HIV through sexual intercourse. When I made this request of my physician, part of the dialogue that we had was about, my sexual history, which is very common to do. And I disclosed to the physician that I was bisexual. And we finished our discussion, and the physician, left, and I didn't get a prescription, which is what I was hoping for. And he sort of said like he would have someone from the office contact me later about the prescription. And I was like, okay, I never had that happen before, but whatever. There's healthcare is complicated, so I'll play along, right? And I remember day after day went by, a week went by, 2 weeks went by, and I started calling, and I was like, hey, what's going on here? I met with Dr. So-and-so. I'm still waiting to hear back about my prescription. And months actually went by, and I continued to call the office, and I never heard anything back. And the next time I went in to meet with a physician, I had a new physician, and I thought that was really strange. I was like, where's Dr. So-and-so? I love that doctor. He was the best doctor I've ever had. And the new physician, was kind enough to explain to me that my previous physician had a conscience objection to writing that prescription for me because of my sexual orientation. And that was really kind of a shock to me, quite honest. I didn't even know that physicians could have conscience objections in the first place, much less this kind of conscience objection, right? Because this physician didn't object to writing prescriptions for PrEP. He objected to writing prescriptions for PrEP for people like me, right? Is really what it came down to. And I actually want to, sort of pivot here a little bit and invite Professor Fox to, so that's the ethical landscape, sort of my personal experience, and invite Professor Fox to say a little bit about the very interesting legal nuances about conscious objection with respect to LGBTQ discrimination. So Professor Fox, please tell us a little bit more about the nuances of the legal landscape of this kind of conscious objection in the US.
So sexual orientation and gender are not among the classically protected groups that I mentioned, are usually protected by the civil rights laws as a limit on conscientious refusal, the way that age, sex, race, ethnicity, national origin, religion are. There are a couple of exceptions. For example, civil rights law in California called the Unruh Act does include sexual orientation within the scope of state civil rights protections, but that's again the rare exception. Accordingly, gender and sexual orientation are legally permissible grounds for conscientious refusal and its protection in much of the US. I think that this is not good. I also think that it presents some hard questions under certain contexts. I mentioned California as one exception. A case that arose there, I think, is a useful point of departure, because again, I think it challenges any easy answers on this question. An unmarried lesbian couple sought fertility treatment from a reproductive endocrinologist there. It was a clinic, 2 doctors who refused them service on the grounds that they were unmarried and gay. They would provide IVF treatment to married straight couples, but not who were of different sexes, but not to unmarried ones, single people, or to lesbian couples like them. Now, the facts of the case relied largely on the doctor's religious beliefs and whether and their freedom of religious exercise coming up against the civil rights of the couple, not to be discriminated against on the basis of their marital status or sexual orientation. But let me change the facts just a bit to align it more closely with the kind of objection that Dr. Collier articulated in her remarks. Let's say that the doctors gave this as a reason. We have no negative attitudes or judgments toward people on the basis of their sexual orientation or marital status. We don't think that single people, gay people, lesbian people, trans people are any less worthy of being parents, deserve children any less, should have any less right to form their families how they want. But we have a view of medicine, what its moral values are, what its goals and purposes are, that narrows its objective to that of healing, that is, to identifying injuries and illnesses and treating those or curing those, maybe in relieving suffering to some extent, but not using clinical practices or procedures to do other things that people might like, might even enhance their well-being, but don't address this singular goal of healing, they say, on this conception of medicine. Accordingly, for different sex couples who struggle with infertility, they can point to bodily problems with the production of sperm or their ability to carry a pregnancy. A condition might be diagnosed that fertility treatment could be said to respond to. And that's what medicine does. That's what it's supposed to do. By contrast, someone who is single and unpartnered, or someone who is in a same-sex relationship, nothing is wrong with their bodies per se. It is rather something else, a social or lifestyle reason that medicine would be responding to in their case. And that's an improper use of medicine. Again, so this argument could go. The effect or impact of that decision not to provide fertility care to this couple would be the same on them. They wouldn't be able to have the chance for biological children, or for one of them to be biologically related the way that many other people, for the very same kinds of reasons, want to form families in that way. They would miss out on that, lose out on that. In this particular case, what happened was they were able to find another provider, but not one that was covered by their insurance. And accordingly, they had to pay quite a bit of money out of pocket they wouldn't have had to were they not conscientiously turned away or on basis of religious beliefs. I find it difficult to say whether the conscientious objection of the doctors ought to be protected in the variation that I described. I think it's much easier if the reason is because of gender or sexual orientation, for the grounds that that is so characteristically associated with negative attitudes, assumptions, stereotypes about individuals. And that, to me, should not be a morally or legally permissible ground to deny someone access to medical care that is within the norm, that is practiced as a matter of standard of care. Certainly IVF is within this space, including for same-sex couples. But I think it is harder when the nature of the conscientious objection is articulated in the way that Dr. Collier described. And there, I think there are arguments on both sides that must be reckoned with. Ultimately, I think it is again, as I mentioned in my earlier remarks, in large part a function of the impact on the relative stakeholders. If they would not otherwise be able to get this care, then I think that would merit in favor of not protecting conscience and not providing an accommodation. If care were readily available, I think that would leave space to protect conscience in both, as Dr. Collier mentioned, for the individual integrity of the providers that is legitimate, and then also I think to create space within this pluralistic practice of medicine for people to disagree and to have their dissent taken seriously from within, again within limits dictated by the practical impact on these third parties. And so I think that in general, the kind of singling out that Professor Brummett describes ought not to be permitted. But there are harder cases where it is more closely aligned with views about the morality of medicine that strike me as tougher, at least in principle, if those are the reasons.
Thanks, Professor Fox. You know, as I was listening to you articulate your response, and thank you also, Professor Brummett, for covering the ethical landscape and sharing your personal experience and for giving voice to the patient perspective. I think it goes without saying that there are no easy answers here. We're talking about diverse human beings with their own individual needs and perspectives, who are taking care of diverse human beings with their own needs and perspectives. And so I'd like to pose one final question to the group. It's not an easy one, but I think it's a useful one to tie everything together. And that is, how do you think we can, or do you think we can do to balance providers' conscious rights while also ensuring that LGBTQ plus patients receive the care that they need in a non-discriminatory way? Dr. Collier, I was hoping you might be able to speak to that first, but don't want to put you on the spot.
Thanks. No, thanks, Reverend Bona.
All right.
What a rich conversation today. I just wish we had several more hours to unpack all of the nuance. So yeah, I think when we get down to it, I think here are the questions I think we've been wrestling with in this conversation today, whether or not we've sort of said them out loud. I think it's the question of like, what is the nature of a profession and its role in a pluralistic, democratic republic? And two, like, what does tolerance mean when it's applied to public practices that are morally controversial? And I think in these conversations around conscience, I think sometimes this has come up today, the issue isn't the issue. Often the issue of physician conscience gets buried under what ends up being a contentious debate, not over conscience per se, but the contested issue itself instead, like abortion, euthanasia, et cetera. So I think there are two separate but important questions at hand. One is whether practitioners should be allowed to opt out of providing certain contested procedures. And the other is the nature of these contested practices, like IVF or abortion, euthanasia themselves. And obviously we focus today more on the former, obviously, and both are important to have. But I think it's important to not conflate those two, although they're related. And, I would love to come back at some point, Professor Fox, and talk with you about abortion, because I do take issue with some of the way you frame some of those cases. But so both topics are important to talk about. So with regard to your specific question, Reverend Bona, how do we balance conscience rights of healthcare professionals and the rights of patients to legal practices and procedures? So I'd like to suggest some solutions that bioethicist Dr. Xavier Simmons has outlined in his really important book, which I highly recommend for folks. It's titled Why Conscience Matters, A Defense of Conscientious Objection in Healthcare. So one is a proposal that he writes about, that was written about actually by Dr. Fernandez Lynch, which is like a doctor-patient matching system that could be facilitated by the site licensing boards. Another idea is different, but somewhat related to the first idea that, that Xavier himself argues for in his book, which I think is super interesting, which is a national database of sorts, not where the conscientious objectors would register, as many would find it offensive to require citizens in a democratic state to register their intention to exercise their fundamental freedoms, but instead where people who do want to provide these services could register so that patients could find them. That idea is probably the best idea that I've heard. It's definitely not perfect, and we want to think about burdens on patients, and especially in medically underserved areas. But I think it's one that deserves some serious consideration. Again, thanks for inviting me to participate today.
We're glad to have you, certainly. Professor Brummett, what are your thoughts on the question at hand?
Yeah, so just two things come to mind. Well, really three things. So one thing is pretty simple, and it's that even though, as Professor Fox has informed us, it can be legal to, not provide just even basic medical care to LGBTQ persons where a provider lives, just consider not doing it. I mean, that would be one. So like, just because it's legally permitted to do that somewhere, the AMA, lots of medical organizations would reject that kind of discrimination. And again, because the ethics and the law can come apart. That's kind of an easy one. Another one that I wanted to talk about was this distinction between referral and advance notice. I think that when you're engaging in a non-discriminatory form of conscious objection, if the provider is comfortable, providing a referral to the patient, they should do that. But I understand and, am familiar, there's a lot of literature around concerns with moral complicity just in the provision of a referral. So basically the argument is that, if you're asking me to do something that I find so morally egregious that I'm going to evoke a conscious objection, telling you where to go to get it done is a short step away from me doing it myself. And I can see, how a provider would feel that way. But I think an alternative to referral, if you're not comfortable with referral, is to engage in better advance notification practices. This is something that we know a lot of institutions that exercise conscious objections do not do well. And there's no studies, at least that I'm familiar of like particular like small clinics and how they sort of navigate this, outside of like big hospital organizations. But I think that engaging in better advance notification, which is nothing about, you can go here to get it. So that's what makes it different from a referral, is a good way to try to better inform the patient population that you treat of, certain moral restrictions in your medical practice that can prevent, situations where they find out in the clinical encounter and now they're upset. Maybe they had to take off work to come see you. I mean, there's so many reasons why that could go bad, right? A third thing specifically for the LGBTQ community, and even specifically for my situation, is improving access to telehealth services, especially for a lot of these prescription services. I mean, PrEP is a perfect example, right? PrEP is not a procedure that I need done. We don't need an OR to, to give PrEP. It's just a prescription. And, improving our telehealth services really is a way to lower burden to treatment without having to, override conscience laws or, anything like that. It just seems like a rather easy way to help enable access to the LGBTQ patients. And I know this is done already. I just think we should keep going in this direction. I think it's a promising direction, but that would be a third thing that comes to mind.
Wonderful. Thank you all for sharing so openly and graciously of your knowledge, your experiences, both personal and professional. And I think you really highlighted the degree to which this is such a nuanced topic. I'm leaving this conversation feeling both more informed and having new thoughts and questions that I didn't have before listening to this conversation, which I really appreciate. To all those who are attending live, we'll be sending out a short survey later today on the panel. We appreciate the feedback to ensure that our resources are meaningful and useful. If anyone has any questions or thoughts and wants to reach me at the healthcare program at Tannenbaum specifically, you can email me at healthcare, all one word, healthcare@tannenbaum.org. And stay tuned for more information on our e-learning course on conscience rules, which will be available for free on Tannenbaum's website very soon. So thanks again to everyone, and I hope you have a great day.
Thanks, everybody.
Thank you.